and welcome to the Home of Medicine podcast with me, Dr. Amie Burbridge. I am very excited that this is the start of season 2. We had a really successful and fantastic season 1, and part of that success was made possible with the fantastic
Dr. Stephen Laird.
So Stephen Laird is a microbiologist in Coventry, and we work together, and today we are going to discuss some cases, but this time I am going to be doing all the answering. So Stephen, over to you.
So I've got a really interesting case, something that we don't often see here in the UK, but some of our colleagues who are listening to this will see this all the time. So there's clue 1. So I've got a 50-year-old gentleman who presented to a district hospital, so a small hospital in the UK, who came back from somewhere. You're going to ask me where, and we're going to go through our travel history, with fever, abdominal pain, diarrhea, which then turned into dysentery, so bloody diarrhea, and he was found to be biochemically leukopenic, so his white cells were dropped, his platelets were dropping at a significant rate over the next couple of days of his admission, and he was in renal failure. His other symptoms, which are important symptoms, were headache, myalgia, mild arthralgia in most of his joints, big joints and little joints, no photophobia. So those are the bits that I'm giving you for free. The rest you have to work for, Amie.
Okay, so this is a 50-year-old gentleman. Does he have any past medical history of note?
He likes a drink, this gentleman, but he has on ultrasound, never diagnosed previously, a mild cirrhotic liver.
And when you say he likes to drink alcohol, how much alcohol would we be talking in a weekly basis?
So he would have maybe a bottle of whiskey in a 4-day period.
And is that a litre bottle of whiskey?
It's a 70 cl.
70 cl, okay.
Yeah.
So he's drinking around 140 centilitres of it's very strong whiskey and liquor per week. It's way over the recommended amount of alcohol. Is he a smoker?
He's not a smoker at all, but one of the things that is of note, where he came back from, the reason he was out there, so I'm going to give you this for free as well, because that's going to be a part of your travel history, I'm sure, is that he was seeking medical help. He was actually in a hospital having a discectomy. So he had a very severe back pain for a while. He went back to his land of origin, and he had some spinal surgery.
So he had spinal surgery. So did these symptoms start after the spinal surgery?
A long time after his spinal surgery.
How long are we talking?
We're talking, he was in his country of origin for a couple of months, recuperating, rehabbing. And so he'd been in hospital, and then he came out, rehabbed at home in an urban area. And then his symptoms started 3 days before he left to come back to the UK, where he resides now.
Okay, so it's a couple of months then?
Yeah.
Okay.
Yeah.
Any recreational drugs that he takes?
He doesn't know.
No, okay. So a 50-year-old man who has a high alcohol intake, who's recently travelled and has got fever, abdominal pain, bloody diarrhoea, headache, myalgia, arthralgia, lots and lots of things going on. So let's go right back to the beginning then. Where did he travel to?
Where did he travel to? So he travelled back to India.
Okay, and whereabouts in India?
Thank you for asking that, because a lot of people just leave it at that, and that's a really important part. He travelled to the northern region, north of Delhi, in one of the big cities called Ludhiana. Or Ludhiana. It's spelt. If you don't know what people are saying, then I always ask them to spell it out, because I had to Google this myself. But it's a really populous urban city, so it's spelled Ludhiana. Then I Googled it because I wanted to know if there was any infectious outbreaks around that area.
Okay, so he travelled there for spinal surgery.
He did.
Okay, and did he before he went to India, did he have any recent infections?
No, not to note, no, not at all. He's relatively well, except for the back pain, and that's the whole reason he went there.
And was he fully vaccinated against COVID?
He was, yeah. He's fully vaccinated against everything, actually.
Okay. So one of the things that this could be is COVID. And the reason I'm saying that is because COVID mimics lots and lots of infectious diseases. So that's something I'd always want to think about, given the fact that although we are sort of through the worst of the pandemic, the number of COVID cases is rising.
Yeah.
So it's always worth thinking about COVID. And certainly in the last couple of weeks, I've seen an increasing number of patients who do have COVID. Often they don't come to hospital with COVID, and it's often an incidental finding.
That's true. And it doesn't usually play around with your blood work as much as I give you. And that's why I give you that little bit of information, so we could start to think about how investigations are going to help us here. And there is a travel history. There should be something as an acute medic we're thinking at front door with regards to this gentleman who's came back with a fever and he's bleeding.
Okay, so what's the length of these symptoms? So how long have they been going on for?
In total, 6 days.
6 days, okay. So he's been unwell for 6 days. Okay, a few more questions. Does he have a rash?
He had a mild rash. He's quite dark-skinned, but there seemed to be a very mild rash throughout all parts of the body, not coming from the back of the ears and down the chest, not starting at the front of the chest, and it was a macular rash. Okay. It was like a viral exanthem.
Was it an itchy rash?
It wasn't an itchy rash.
And the reason I'm asking that is, I don't want to assume that this is an infection, because actually some of the symptoms that you suggested could indicate an acute rheumatological emergency.
Sure.
So although it doesn't have a past medical history of a rheumatological emergency, and actually it was 6 days history, other things that do go around in your head when you see these sort of things are, is this a rheumatological vasculitic process that is going on, or is this a vasculitic process going on secondary to infection? So yes, I'm talking to a microbiologist and we're discussing a travel history. So, you know, our cognitive biases are automatically leading us towards an infection. But sometimes it's worth stopping and thinking, checking on our thought process, thinking out loud and going, actually, could this be something else? Could this be, does he have rheumatoid arthritis? Does he have an acute inflammatory large vessel vasculitis or a small vessel vasculitis? They are all possible, so it's always worth thinking about.
And these are the things that we would think of as microbiologists, as physicians in microbiology as well. They promote this. These are the things that also cause fever, which is basically what I work in.
Absolutely, yeah.
This fever, however, you never asked what type of, how high.
Okay.
Because people, unfortunately, use fever and pyrexia when it's not. Okay, you can be hot outside your normal norm, that's fine. You can have a 37.4 and you can be hot. But when we talk about fever, we're really thinking about the 38.1s and above, aren't we? Okay. This guy was 40.1.
So that's a really good point, actually, moving forward. And something I'll take away from today is, what type of fever is it? Is it a persistent fever, or is it a swinging pyrexia? Does it get worse at night? Does it have associated night sweats?
Okay, so it was a persistent pyrexia, so it didn't come in waxes and wane. So we kind of think of that with malaria. We sometimes think of that with abscesses as well, kind of when they cause a bacteremia at certain points, escaping from the held area of where they're creating an abscess. But this was a constant fever. He was burning up, this guy.
Okay. Was he very sweaty with it?
Yes.
Okay. Any problems with his urine? So it is urine change colour. So he mentioned that he had renal failure, some bloody diarrhoea, and obviously he's very unwell. Was his urine output very low?
It was, until he wasn't drinking and eating very much because he was nauseous, and on occasions he was vomiting, but there was no blood in his urine, which was another important point. So he didn't have a dark Coca-Cola-like urine, for example, and there was no frankhematuria in there either, even though he was catheterized, even though his platelets were dropping.
Right, okay. So did he take any other medication of note at all?
There was some pain relief that he was on, simple analgesia,
Okay.
paracetamol, some NSAID, so I think it was ibuprofen that he was on. Again, could cause gastric irritation and lead to an upper GI bleed. So all good processes, all good thoughts. Nothing to stop the fever though. So he's on paracetamol, so he's on these antipyretics, but actually his fever was still there. Yeah.
Does he have any significant family history of note?
That is a part of my history that I didn't take.
Okay.
So I don't know actually.
Okay.
It's part that I never asked because I kind of had a feeling of what it was, my bias. So yeah. Okay, I don't know the answer to that.
And did he travel with anybody?
That's really good. That's one of the things that people always miss out as well. If someone else is sick and they've had common epidemiological risk factors, then that really helps, doesn't it? He did travel with people. He travelled with his wife. His children weren't there at that point, but his wife was absolutely fine.
So she didn't have the same symptomatology?
She didn't have anything. She was well.
Okay, so now I'm going to ask a sexual history.
Okay.
So he's got a fever. I mean, you said he travelled with his wife, but from a sexual history perspective, was he sexually active? Was his wife his only partner, or was he having extramarital sexual relations?
Wife was his only partner.
Okay.
And there was no sex whilst abroad.
Okay.
He was too unwell. He was recovering from the hospital stay, but that doesn't mean that he wasn't having sex.
No, absolutely. And in the last sort of 3 to 4 years, had he had any extramarital?
Not that we know of. We didn't dig in that deep, that far back.
Okay.
Because again, even though it's a really good point, and we always bang on about sexual history shouldn't be taken, at some point you need to know your limitations of what is actually relevant within that conversation as well. And at this point, we didn't think it was relevant, but we would have come back to it if we didn't get the answer we wanted.
That's a really good point, actually. So you start with what gather the information that you think you need to gather at that point. If that doesn't help you, you go into then a second information gathering process.
Yeah, and if you don't know what's going on at all, you go for as much information as you can get out of somebody, right? Yeah. That's what a history taking is all about. If you do not know what's in front of you, you have to ask those questions, because if those answers might actually lead you down the right path diagnostically from a clinical point of view.
Yeah, absolutely. And as I always say, I have to say every single episode, listen to your patient. They are telling you the diagnosis. And actually, a lot of our diagnoses are going to come from a history, aren't they?
They are.
And our investigations are confirmatory. So just want to find out what his general observations were like. So his blood pressure, pulse, what were they?
We brought him through resus and straight to ITU. This is where I met the gentleman.
So he's very poorly.
He required ITU, he required inotropic support, he required fluids. He looked well to start off with, but then he deteriorated and he needed intubating.
Wow.
Yeah, so he really deteriorated, and over a period of a couple of days.
Okay, so when he originally came in, then he was okay, but he deteriorated rapidly. So he was hypotensive, tachycardic. Was he hypoxic?
He wasn't actually. He was very tachypneic, as you'd get when you start to lose fluid. But no, that was just a part of his acid-base kind of reset.
So he was septic.
He was septic.
Okay, so when anybody got anybody with sepsis, then we have to follow that sepsis bundle.
Sure.
And out of interest, what was his lactate?
His lactate was 5 on admission.
Okay, and did that climb?
It did, but then with fluids, it kind of came back down. So we only got to about an 8.
So, I mean, we want a lactate of 2 or below is a normal lactate. So 5 and high is obviously shows that he's very unwell. And what about his pH?
I don't know off the top of my head.
Okay, so just always worth thinking about, isn't it, that venous blood gas or the arterial blood gas to look at that. Okay, so he ended up in ITU, but basically what I'm doing now is trying to think about what could be going on. So whenever it comes to infectious diseases, because I'm not an infectious disease specialist, I go through my head and I write down fungal, bacterial, viral, others, parasitic. And then what I do is I then think about what are the bacterial conditions this could be, what are the viral conditions this could be, what are the fungal, and so on and so on. So there's a diagnosis in my head that I'm sure is completely wrong. So I'm scared to say it, but that would sort of fit the picture. But I don't want to jump in there too soon. What I do want to do is talk about my thought process. Okay, and how I'm going to get there. So he's acutely unwell, he's septic, he's got a huge number of symptoms of the headache, the myalgia, the arthralgia. Just a few more blood tests, actually. What was his CRP?
His CRP was 126, so it wasn't stonkingly high, but it was high. So C-reactive protein, 126.
And what we'd like that to be is less than 3.
Absolutely.
Liver function tests.
Liver function tests, so his ALT, which is what we use dominantly rather than AST in the UK, it was 82, so high,
Okay.
but not stunkingly high. His
No.
alk phos was 140, and his
So a little bit high.
a little bit high, and his bilirubin was a little bit high at 35, but not massively so.
And what was his HB, hemoglobin?
Dropping because he was losing blood.
So was he hemolyzing?
He might have been.
Did we do a blood film?
We didn't do a blood. Well, we did because we did a malaria test, but we didn't do to look at what type of what was going on with his cells. We did look at his platelets a little bit, and they just seemed just to be low. There seemed to be an obvious thrombocytopenia going on.
Okay. Did he have any schistocytes on the blood film?
No.
Okay, and is it LDH? Is lactate dehydrogenase?
I have no idea what that was.
Okay.
We didn't do it actually.
Okay.
Yeah.
So that can sometimes be high when there's hemolysis of the hemoglobin, of the red blood cells, and also when there's increased cell turnover. Okay.
So when he first came in, his hemoglobin, which we might have different units in throughout the Europe, but his hemoglobin here was 120.
Okay.
So that dropped to 80 in a period of 3 days. So he needed support.
Okay.
He needed blood product support.
Okay.
And there was a reason why we gave him blood product support as well.
These are all clues, aren't they? That I'm trying to fit together. Okay, so what I'm going to do, I'm going to think about what else I need to do at the bedside. I want to do a blood glucose level. I'd like to do an ECG. I want to find out if there's any heart block, because sometimes that can happen with infective conditions. We've talked about doing a BBG. Blood tests, we've done the full blood count, U's&E's, LFT, CRP, blood cultures.
Yep, absolutely.
I would like to do a clotting screen or coagulation screen. His liver function is abnormal. He's dropping his platelets. What's his coagulation like? Is he at risk of disseminated intravascular coagulation, given the fact that he's acutely unwell and he's now in ITU? Other blood tests that I'd like to do, blood film, which we've talked about. I've talked about doing LDH. We could do a blood test that looks for whether he's hemolyzing. I forgot the name of that test. Can you remember it, Steve?
Coombs test.
Coombs test. Okay, take that out of the podcast. We'd also like to do a Coombs test, which would look at whether there's hemolysis. And then I need to do lots more infective tests, which is where I'm going to need a little bit of help on.
Sure. And so you'd ring us up and you'd ring virology up or whoever.
I'd do a COVID swab, because I can do that. I'd do some blood cultures.
Yep.
Diarrhea, I'd probably send off for stool sample as well to see if there's any bugs in there.
So the reason that I brought this to you, Amie, is because there's one thing that we didn't do in the management of this patient, that when I came in and saw this patient 3 days after his mission, I really wish people had thought about.
Okay, flu.
No. Well, yeah, not diagnosis, but action. Front door. I've got a gentleman coming back from a country with a viral exanthem, bleeding, and he's got fever. So he's got a viral hemorrhagic fever until proven otherwise.
So what was going on in my head a little while ago was Ebola virus.
Right. And that's absolutely, I would rather you thought of that than ignored everything that came through and not put actions into place and found out later that this was the scenario. Now, this gentleman's in North India. So if you rang us up and said you thought he had Ebola, I would say, no, that's actually, that's probably not the case.
Okay.
But, there's still outbreaks in the world. There's Uganda's having problems with it, and we still see it in the Congo and in the Democratic Republic of Congo. But we do have lots and lots of other viruses in the world which can cause hemorrhagic diseases. Some of them are... Go on.
I'm struggling.
No problem. So you would ring us up and I would say, okay, I'm going to come and see this guy. Oh my God, have we put him in isolation? Are we worried about Crimean Congo hemorrhagic fever? Are we worried about that? We very rarely see it in this country. We've only seen a couple of cases in the last couple of decades. However, what is more common in northern India are a couple of other things. One is an old rheumatology reg. You'll have probably come across chikungunya causing arthralgias.
I've actually seen a couple of cases of chikungunya.
but this doesn't put people in ITU.
I was going to say, when I've seen chikungunya, they've been quite well
Yeah.
patients.
They
not
usually
well.
they're usually febrile, have really bad kind of viral reactive arthritis, big joints, and sometimes even need rheumatologists to give them some form of DMARD or prednisolone, unfortunately, for lifelong. It usually, though, is something that gets better. The one that can make you very, very sick that isn't transmissible from person to person unless you've got a mosquito, usually Aedes aegypti or albopictus, is dengue.
Oh, God.
Yeah?
Take the oh, God out. Oh, yeah.
Dengue. So dengue, so I don't ask people to know about the rare, wonderful encephalitises, you know, the equine western encephalitis, you know, I don't need you to know all of that. But those other things that we think about is, one, is this a viral hemorrhagic fever? Do I need to isolate? Do I need to make sure that everyone around us is safe? Is there an outbreak of something which is human to human transmissible, like Ebola, like CCHF, Crimean Congo hemorrhagic fever? Is this Lassa fever, etc., Marburg's? We're all having outbreaks of these viruses are big news now because COVID's made infection big news again. So we're looking for the next virus. At the moment, we're seeing group beta hemolytic group A strep outbreaks. Unfortunately, a few of those children have passed away with really bad scarlet fever disseminated into disseminated group A strep, causing sepsis. But what I do need you guys to think about is, one, viral hemorrhagic fever, do I need protecting? Or is this something like malaria, tuberculosis, HIV seroconversion, dengue? These are the common ones that are absolutely everywhere, and they should be on the top of your mind when people are traveling.
Okay, yeah, you're completely right. And it's really, it was a blank. I had Ebola in the back of my mind, but I was like, Ebola doesn't really affect that area of the world.
Yeah.
But I couldn't think of anything else. So,
but if you were thinking of that, you were thinking of something similar, and that's the thought process that we would want everyone to have at the front door. Is this something horribly scary to the patient and transmissible to us?
Yes. Okay. So you've got a viral hemorrhagic fever, then we've got dengue. So how did you investigate for dengue fever?
So you can, there's a couple of different tests that you can do. There's serology, which is available. Sometimes it's helpful, sometimes it's not. The IgM sometimes doesn't actually show. And people who are in dengue endemic areas will usually have an IgG, which is positive. Lots of people will have dengue and be asymptomatic. Lots of people. They don't have to have, they might have just a very mild illness. There's 4 different types of dengue. And the thought process is still unclear, but the common thought is, if you get 2 different types of dengue in your lifetime, the different serotypes, then you will have a worse outcome on that second episode.
Right.
So this guy actually was IgG positive, but then we sent off the PCR test to see if dengue virus was actually present in his blood, along with a panel of other things, especially CCHF. We rang up the imported fever service, and we rang up the reference lab as well and spoke to the travel parasitology experts and the viral experts to say, is there a potential, because I know that this is in northern India, but more commonly CCHF would be in kind of your very Eastern Europe, going into slight Western Europe and other parts of the world. Is there a potential that this could be this? And actually it didn't match up. It matched up so classically with severe dengue. So there's dengue fever and there's severe dengue. There used to be different types of categories, but it was simplified around about 2009, 2010. So this was severe dengue, and that's what we don't see often. We see lots of dengue in the UK, usually imported back, but we don't see people who require blood product support, ionotropic support, ITU support, and actually this gentleman got an endoscopy as well because he continued to bleed. And with his drink and with the NSAIDs, then we wanted to make sure that there wasn't a dual pathology, and that was a good call from ITU and the gastroenterology team, and brave as well. But luckily we had gastroenterologists who had dealt with a lot of dengue from Malaysia, from her country of origin, so she knew what she was doing.
Gosh.
Yeah,
So
interesting case.
how was the treatment supportive, isn't it, for dengue?
Supportive, yeah. There is trials. There are trials out there at the moment for acute dengue, but we're not at that point for normal treatment. We just blood product support when they're starting to drop. And there are different protocols around. We kind of treated this gentleman like a big GI bleed.
Okay. And is there any link with disseminated intravascular coagulation? Do they develop DIC?
I don't know if you could actually tell with this guy.
Okay.
His blood products,
Okay.
his hematology was so out there.
Yeah.
Then
Okay.
yeah, you probably could. The fibrinogen probably has been utilised, etc., etc. But I don't know that to be honest.
Okay. Very interesting case.
Very interesting case.
It's got me thinking on this early Tuesday morning, and I'm sure there are lots of people listening shouting from the very first presentation that this was dengue, but certainly in the UK, this is not something that we see very often. No. I'm aware that we probably see this a lot more in other countries and much more used to it, and then how it presents. So from key take-home points for me are, I think, number 1, think dengue. Number 2, think dengue. Number 3, think dengue.
Yeah.
And then also to ask about the fever and the type of fever, and how high is the fever. And also the other thing that I guess we didn't cover was he'd had a big operation.
Yeah.
So could this have been a post-operative infective complication, not the dengue? And would his operation and his prolonged recovery period have put him at an increased risk of developing severe dengue?
No, I don't actually think it would have. Been bitten by an Aedes mosquito, having the virus in there, and having dengue previously would be the risk factors.
Okay.
Him not having the greatest of livers didn't help. And the other thing, my take-home messages would be, yes, think dengue, but think viral hemorrhagic fever when people are coming back with fever and they're bleeding. They have obvious signs of bleeding. Because the take-home message really for me is make sure that everybody around you is safe before you start investigating the sick people that are in front of you. That's what we do when we do resuscitation, right? We first look around and then we go to the patient, and that's what we should be doing here. The other little take-home message is, which we haven't touched on from a microbiology point of view, is this patient has been in another country, in another healthcare system. Please make sure that we do our CPE screening, because this guy had 2 different CPEs in his bowel. So these are carbapenems producing Enterobacteriaceae. These are the bugs which live in our bowels, which are resistant to our last kind of broad spectrum antibiotics, the carbapenems, meropenem, imipenem, doropenem, ertapenem, for all of those different countries that use those different antibiotics. So we also need to make sure that when he's in and we're looking after him, that we're not spreading around these bugs which have transmissible plasmids. So that's another thing when people are traveling, or even from local areas these days. Make sure that we screen and doing our CPE screens.
And how do we do CPE screens?
So it's a rectal swab.
Okay.
It's a rectal swab. It's a dual swab, and we make sure that we get a swab which hasn't got too much feces on it, because it doesn't work. It's inactive if it does. And we do a PCR test in this trust, and then a secondary culture.
Thank you so much.
There we go. A little
fantastic
extra.
Yeah, thank you so much for sharing that case. I mean, it's a very short amount of time. We've covered a huge amount of things and learned a lot. So I hope that people, when you have a listen of this out there and you are shouting the diagnosis when you're listening, going, why hasn't she got it? It is about what you've taken away from this podcast today, and then share that with other people around you. Either get people to listen to the podcast, tell your friends, your work colleagues, everybody to have a listen. And if podcasts aren't for them, what you could do is they could go and have a look at the online EFIM Academy, which will also share learning and other information. Or what you could do is you could take away the learning points from the podcast and share these around your local hospital department. Thank you so much for listening. And Steve, thank you so much for joining me.
Thank you.
Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.